All right. Well, hi, everyone. I just wanted to say thank you for joining us and welcome to the Association for Academic Surgery Town Hall on Racial Discrimination in Academic Surgery. I'm Callisia Clarke. I'm a surgical oncologist at the Medical College of Wisconsin and a member of the AAS. And I just wanted to tell you a little bit about how we decided to put on these series of town halls. At our summer retreat for the AAS, a little under a year ago, we were strategizing about what we wanted to do with the AAS and what we wanted it to look like. And diversity, equity, inclusion, and justice were themes that came up throughout every discussion that we had. And we felt like as an organization, we had a lot of opportunity for improvement. I was really pleased to sort of serve as the chair of the Diversity, Equity, and Inclusion Committee. And we had started the work of trying to figure out what was AAS's role in trying to tackle this problem. And one of the things that was definitely clear was that we are very committed to trying to at least address health inequities by trying to improve the diversity of the surgical workforce, specifically in academic surgery. And so that was a goal that I thought everybody was all committed to and really fit with the organization's mission. The recent events have sort of highlighted that our efforts so far have really not been sufficient, and it's really re-energized the organization and our committee to focus on doing the work. And so this town hall is one in a series of town halls that we hope to host that will generate not just discussion, but solutions about how we can sort of change the landscape of academic surgery and improve the experiences of our trainees of color and our faculty of color. So co-hosting with me today is Colin Martin from the University of Alabama, and he's gonna introduce himself for a while. We also have some fantastic speakers today that I think are going to really generate some discussion. We have a pretty high number of attendees, so thank you guys for all joining us. You'll be able to submit questions to us via the chat function, and then we'll try to integrate those questions with our speakers throughout the session today. If you want to submit a question anonymously, that is an option. So please feel free to use that, especially if there's sensitive content to your question. But if you want to ask a question, please also feel free to use your name and your institution so we can figure out where you're coming from. And we'll try to make sure that we get to as many questions as we can today. Colin, do you want to introduce yourself?
Yeah, thank you, Callisia, Clarke, and Eugene, Kim, and the AAS leadership. And thank you to all of you who have tuned in tonight. It's a very important topic, and I'm really excited to learn and share and hear from our panelists and you about solutions to address our current state in academic surgery as it deals with racial inequities. I'm Colin Martin. I'm a pediatric surgeon at UAB. I've been a member of AAS for 6 or 7 years, and I'm really excited to participate. We'll get started, and I'll introduce our first speaker. Our first speaker speaking on results of the second trial is Dr. Yue-Yung Hu, who is also a fellow pediatric surgeon at Northwestern Children's Hospital, Lurie Children's Hospital. She's also the Associate Program Director of the General Surgery Residency and does health services research at Northwestern. She's the co-PI with Dr. Carl Villamoria, who's a past AAS president on the second trial. We look forward to hearing information from you, Yue-Yung.
Hi, thanks. Let me just share my screen. Whoops. All right, can everyone see that?
Yes.
So this is all data that just got published in JAMA Surgery, and Tarek is our resident who is responsible for all of this. So thanks to him. Brief funding disclosure. All right, so in other fields, workplace discrimination is well known to be linked to decreased morale, work effort, and career satisfaction, as well as pretty profound personal consequences, including increased alcohol use, depression, and suicidality. Residents in general have been thought to be at high risk for discrimination because of that power differential between residents and faculty, and also because medicine in general, and I think other people will be talking about this later, medicine is not diversified as quickly as other fields, and surgery in particular. In prior work of ours, we found that up to 50% of surgical residents report mistreatment, and that could be any kind of discrimination, harassment, or abuse. Specifically, 16.6% of all residents reported racial discrimination, and any kind of mistreatment was associated with increased rates of burnout and suicidality. So at that time that we had done that survey, we hadn't asked, or we hadn't provided any definitions as to what is discrimination. And there were a lot of questions to us about what does that mean. So in 2019, we decided to dig deeper. So we give out the ABSITE survey, which goes out after the ABSITE to all residents training in ACGME accredited general surgery programs. There is a preamble that says the survey is optional and anonymous. So the data gets de-identified before it gets transferred to us at SoQuick. So we have no way of tracking back who said what. So this year, 2019, we asked about specific behaviors based on race, ethnicity, or religion. And we asked about whether people had experienced any of those behaviors within that academic year. So remember, the ABSITE is in January, so we're really talking about the 6 months from like June 2018 to January 2019. So we asked them about how often they experience those behaviors as well as where they come from. And then finally, we asked about a couple different markers of wellness. So the Maslow burnout inventory to assess burnout, whether they'd thought of leaving their program during that academic year. So again, within the last 6 months. And then if they'd thought of taking their own lives within the past 12 months. We obtained some demographics data from the AAMC about the faculty. We built multivariable regression models looking at both resident and program characteristics. And finally, we did just chi-squares to assess for associations between discrimination, specifically racial and ethnic discrimination, and burnout, suicidality, and attrition. So there are, there were 6,956 clinically active residents that responded to the survey, which is about 86%. You'll see the racial breakdown there. So 4.5% of surgery residents are Black, 17% Asian, 8.4% Hispanic, 5.3% other, and another 5.1 who didn't say, and 1.6 who didn't respond. Of those, 5,679 responded to the questions about racial discrimination. So this, you'll see, shows prevalence. So among all residents, everybody responded, 23.7% report some sort of racial or ethnic discrimination. And of non-white residents, it's 41%. If you look at the specific subgroups for Black residents, it's 72.3%. For Asians, 45.9%, Hispanic, 45.3%. And if you further break that out into white Hispanic versus non-white Hispanic, that rate goes up for the non-white residents. And then finally, other or did not identify, it was 33.3%. And you'll see it's a range of frequencies, but obviously it's a pretty common experience for people who are not white. A few times a month can be actually quite frequent, right? That's every other week or so. All right, so these are the specific behaviors we asked about and the number one source for each one. So for different standards of evaluation and being denied opportunities, 2/3 of that comes from attendings. For being mistaken for a non-physician or slurs and or hurtful comments, most of those came, the number one source was patients and families. For feeling socially isolated, most of that came from co-residents and fellows, and for being mistaken for another person of the same race, almost half from nurses and staff. In our multivariable models, risk factors for experiencing racial and ethnic discrimination were being female, being not white, and being more senior. So again, this outcome, discrimination, was asked about in the last 6 months. So it's not just a question of, I've been in residency for 5 years, so I've definitely experienced it more. Everyone has the same denominator in this sample. It's 6 months worth. So it seems like there might be something about as you get more senior, perhaps there's more familiarity and people feel more comfortable saying things that are inappropriate to you. We're digging a little bit deeper into that now. And then finally, the number of duty hour violations that the resident reports is also correlated with increasing discrimination reports. So I've only listed the significant things here, but on the right, there's some interesting pertinent negatives. So not associated with reports of discrimination were geographic location, program type, and also the racial ethnic composition of the faculty or residency. Residents who reported racial or ethnic discrimination also reported significantly higher rates of burnout, attrition, and thoughts of suicide. Just some limitations. This is a cross-sectional survey, so these are all associations and not necessarily causation. We always get a question about the timing of the survey, so it happens after the OBSITE, which is obviously a long and stressful exam. I think the bias could go in either direction. So perhaps you get increased reporting because of the stress related around the exam. On the other hand, the psychometricians we work with also think that there's a phenomenon called post-exam elation. So you could be so happy the exam is done that you underreport. And finally, there are unmeasured trainee, hospital, and community factors. So like, which way does your community vote? What is the racial ethnic composition of the patient population that could impact your experience that we are not capturing here? So in summary, 41% of non-white general surgery residents report discrimination. It's associated with higher rates of burnout, attrition, and suicidality. And the sources vary, but basically every party that we ask about is responsible for at least one of the behaviors. And finally, there's no program level characteristics that we could find that were significantly associated with discrimination. So it's clearly a very common experience. It is very destructive and it's pervasive. So it comes from everywhere, and it's basically built into the environment. So it's a complicated problem that it's taken a long time to make. I think the strategies to mitigate it are going to be very context specific and multifaceted. And that's a little bit of what we're working on now. So the second trial is randomizing programs. There's 215 enrolled currently. So the ones in the intervention arm will get aggregated data at the program level about how they're performing compared to the rest of the programs in the country. So they get quartiled on exactly how diverse they are, and also on how many of their residents report each of these behaviors. And then we point them to specific parts in a toolkit that we've built by visiting different programs around the country and seeing what works in different places. And then we try to help them implement those things at their place. So again, this takes a whole team of people as well as all the residents responding to the ABSITE survey, which we are thankful for. All right. That's what I got.
Thank you. Thank you very much. It's really exciting work and data, and really excited to see the intervention arm. I would invite any of our participants, if they have any questions, to do so now. We just have a few minutes before we go to our next speaker. Just a little bit more detail, Yue-Yung, about your intervention. You mentioned that programs that may be performing lower are going to be encouraged to visit other departments around the country who are doing it.
We were visiting programs around the country. So we looked at places that were famous for, the trial in general is about wellness, and of that mistreatment is a piece of it. So we were visiting places that were well known for different things to try to see what they do well, and also programs that didn't perform so well in the survey to see what they do poorly. And then we've built a toolkit based on what we've learned from those places that we're disseminating. We make the connection. So if you're interested in working on a particular intervention, we connect you to the person who's doing it at the source institution. So they don't physically have to go visit them, but they'll help you put into place. So for example, Michigan is doing cultural complications M&M. I don't know if you guys are speaking about that later, but that's something we've been pointing people towards.
Awesome. One other question. So we see that especially Black residents and other trainees essentially experienced higher rates of discrimination than some of the other underrepresented minorities in medicine. And there's some data from the ACGME that I know is not necessarily public, but this also translates into more trainees of color, and specifically Black trainees, being terminated at disproportionately higher rates than their white colleagues. So can you comment a little bit about how we can use this data to try to hone in on what are some of the barriers? And also, how are we going to try to implement this toolkit for program directors, or the people that I call first responders, chairs of surgery, division chiefs, program directors, that really need to be aware of this problem and need to be able to help our trainees of color navigate these behaviors?
So I think for starters, everyone needs, I think you had asked me before, like, should everyone have should program directors have some kind of training? I think everybody needs some kind of training, not even just program directors. Like, you think of all the people who are interviewing for your residency, like, why shouldn't everyone get trained on implicit bias? Mm-hmm. Well, in general, forget even about the interviews. But that said, I think it's difficult to know what is meaningful training. I think a lot of people are doing like the PowerPoints you have to click through your institution. And does that bestow the kind of perspective that we need people to have? We're sort of in the process of putting together these things for a second trial and learning from other programs. I'm like very interested to hear what the other panelists have to say about what they've done there. In terms of the ACGME data, I hadn't heard that until you told me that, but that is pretty sobering data. I think that probably points to, it's a lot of things, right? It's the different kinds of evaluation, right? Different contexts for evaluation. So the same behavior coming from two different residents is interpreted totally differently by the nurse, by the program director who receives the complaint, and it just builds, right? And also the context is different. So, like the recent events that you mentioned, the police brutality has a different impact on different residents. And so there are different stressors on top of residency. So I think there are many things, but a lot of people don't know what they don't know, right? So just for starters, it's important to start talking about these things so people understand that perspective.
And then is there in most institutions, were you able to assess whether or not they had resources for residents to anonymously report discriminatory behaviors, or is this something that you guys are able to tackle later on?
So we just started looking at that. We asked the program directors, we give them a separate survey where we ask them what the resources are. And then we also have asked on the resident survey, like, how many of you know how to report? And it's a surprising number that don't. Yeah. And there's not always that match between the program director and the residents. And even if they know how to report, are they comfortable reporting? That's a totally separate, different issue. Like, do they think that something is going to happen when they report? What's retaliation? What's the risk of retaliation? So it is something we need to look further into. We haven't gotten there yet.
So we've gotten a lot of questions from the audience, and we're really trying to get to as many of these as we can, but we'll have some more time on the back end. I'm going to move to our next speaker. So Dr. Erika Newman is a pediatric surgeon at the University of Michigan and the surgical director of the Mott Solid Tumor Oncology Program. She spent her career committed to innovating novel strategies for faculty advancement in both clinical care, research, and education. But specifically, she focuses on strategizing organizational changes within academic surgery and at her institution that allows for all faculty members to have equal and inclusive opportunities to achieve excellence. She's going to talk with us a little bit about racial discrimination at the faculty level and how these serve as barriers for retention and promotion, and share with us some of the work that she's done to try to tackle this in a very meaningful way and give some solutions for improvement.
Thank you so much. Thank you so much for having me. I really appreciate this opportunity. The tragic murders of George Floyd and Ahmaud Arbery and others in the past few weeks have really highlight ongoing racial tension and injustices that have profoundly affected our country, our communities for many years. The unrest and national demonstrations occurring in the midst of this global pandemic have left us all really sad, angry, and really feeling an urgency to act now and to address and try and make changes. Racism and violence directed against Black and Brown people impacts us all. The structural violence that disproportionately affects people of color and those living below the poverty line has become a public health crisis. And it is our responsibility as surgeons to address these complex societal issues. We now have an unprecedented opportunity to deeply examine how we individually and as our organization can act and how we will respond. We must condemn racism and discrimination when we see it and not go quiet. It is not enough for us to abstain from racism ourselves while it's going on all around us. I do think that this is an important time in American history. I think that the way, the actions that we take will become a part of our legacy. I think we will look back and our children will look back and say, how did we respond? What did we do? What changes were we engaged in, both individually, within our institutions, and within our organizations? And so with that, I think it's really an exciting time to impact change and try and understand the things that we're doing and how we can make things better, not just for people of color and Black people, but for all of us. And so we've been thinking a lot about that. We've been thinking about that both within our professional societies and from our institutions. And I can say one of the things, and so, you know, we've done a lot of these town halls and people have brought to surface some of the racism that has been going on for many years. And Callie asked, and Colin asked me to speak about discrimination amongst faculty and within faculty. And if you all have a chance, I would encourage you to go to Twitter and follow the hashtag Black in the Ivory. There are many, many stories of faculty, students, residents in medicine and in other specialties and other disciplines outside of medicine that have experienced racism as we are climbing this academic pathway. And, you know, so the problems are there, they exist. And what does this mean? Some may think, you know, what does this mean for academics? And, you know, can't we just be about the work of taking care of patients? And I would say that, you know, for us to really be our best, no, we have to really look around and invest and examine, you know, how our departments are understanding racism, how we're understanding gender bias, and all of the things that exclude people of marginalized groups. Because ultimately, you know, this will make us better. And so, you know, did racism lead to the murders of Ahmaud Arbery and George Floyd and Breonna Taylor? You know, ultimately the answer to that is yes. And so how do we lift the community, and how do we lift ourselves to be able to try and prevent some of those things? And a lot of it is just getting more people of color into positions where they are viewed as leaders, as an example, or getting more people into people of color into academics and being successful and being and can contribute to a successful society. So we've done that. We've been doing that at Michigan. We are by no means, we just started this journey. We have we're learning every day. We learn something new about equity and inclusion. And so I just thought I'd share as an example of what an institution might do to become more open and inclusive, to be able to openly address acts of discrimination and hate and overcome racism. And so one of the very first things we did this about 3 years ago now, but we looked at the racial makeup of our department. And what we found, you know, we had never looked at our department in this way, but we saw that over the last 10 years, we had not changed with the number of underrepresented minorities. And in fact, they were very low. And in some years, we, you know, 2 or less numbers amongst 120 or 130 surgeons. And so I would encourage all department heads to take a look at your demographics and just start there. And no, this is not about, strictly hiring or maintaining programs based on the numbers of underrepresented minority faculty, but it is about understanding, what messages that might send when you have an entire department with just one or two people of color. And so we looked at demographics based on race. We also looked at gender, and we thought that we could do better in that space as well. And based on that, we saw a group of us, and this was the department leaders as well as about 30 or 40 people in our department. And I will say that we discussed this multiple years in a row at our retreats, and where the entire department participated in forming the mission and the vision around how we would really address basically those two previous data points, increasing our numbers of underrepresented minorities as well as women. And we thought that we needed to do that to be the best. And at Michigan, I'm as sure I'm other academic institutions on this call, we like to, we're the leaders and the best, and we are, we're competitive and we don't settle. And so how can we achieve excellence without being diverse? And I don't need to make the argument for diversity on this call, because aligning diversity with excellence, I think over the past 5 years in academic surgery has been really laid out. So we all understand the benefits of achieving diversity. But we made this mission. We said we prepare each surgeon to achieve excellence in clinical care, research, and education, that we were going to build a diverse and inclusive culture in which all individuals would advance and thrive. And so we didn't say women, we didn't say Black people, we said all individuals would advance and thrive. We wanted to recruit the best and the brightest clinicians and scientists to the Department of Surgery. We're going to create innovative strategies for ongoing professional growth and scientific discovery. We're going to develop the most talented and progressive leaders in academic medicine. And then we're going to expand outreach and service to local, regional, national, and global partners. And so based on that, we realized that, we had to really make some tough changes, and that sometimes it would be uncomfortable, and that we would really try and break the mold and stretch ourselves to hold strong to that mission. And that without that, we knew we wouldn't be able to achieve it or get better. And so we staged this. We thought, one, we had to socialize this within the department and try and raise consciousness around some of the issues that might be leading to low numbers of underrepresented minorities working in our department and then being successful in our department. We wanted to learn more, so education has always been at the forefront. So we were educate ourselves and educate others in the department. Empowering governance, so having diverse voices at the table was important, and then putting things in place such that the changes would be sustainable. So how do we go about conscious raising? We started to have grand round speakers that helped us push the envelope. And so for a year straight, now I think almost 2 years, our grand round speakers were women. And we intentionally sought out women leaders to give grand rounds. Now, we didn't lower metrics. We still wanted the best and the brightest speakers. And so we made an effort to find that. And so what we found was that when we looked, we would have honored these speakers no matter what. And so it was an intentional effort to find a diverse panel of speakers for grand rounds. This is who we've had over the last 2 years. Scott Page gave a grand round series on his book, The Diversity Bonus. Dr. Greenberg came. Dr. Mark Neve, who was the AAMC's Chief Diversity Officer, came and spoke about how he laid out the diversity plan for the AAMC. Back in February, Adam Foss spoke about Adam is the founder of Prosecutor Impact. He has now become a good friend of mine. I've learned so much from him about how we as academics can use our swords and shields for community empowerment, and how every person you meet, we should be asking ourselves, how can I help you? How can I help you be successful? And that shouldn't just be for people of color, but I think it's exceptionally important for students of color and residents of color and faculty of color, for us with power and privilege to be able to use our swords and shields to protect and uplift and people. And he does that by, he used to be a prosecutor in Boston and would do that for children that were coming to his attention for being prosecuted for stealing things like backpacks. And so he would use he spoke about using his sword and shield to redirect them, not in the prison pipeline, but in other pipeline programs. And so just using our diversity grand round series to raise consciousness. We developed a Women in Surgery Leadership Development Conference, and again, as a way to just socialize the work that we're doing, to learn more, to gain ideas around this work. Empowerment and governance. So our chair at that time, Dr. Mulholland, expanded the Department of Surgery Executive Committee to be more diverse. And so these members were added. And again, they were not added because they, just to add women and underrepresented minorities to the committee, but we looked around the department and these were people that were actually working hard, had great ideas, they were creative, they were devoted. And so the executive committee was intentionally expanded. That's just us again. He made new vice chairs. And then how do we sustain change? And so this has been really fun and exciting. And if you follow us on Twitter, you have saw us really proud about the Michigan Promise. Again, I will say this because I don't think I can say it enough. The Michigan Promise is our starting point. This is the beginning of our journey. We are learning more every day. We hope that in 10 or 15 years from now, we can look back and say that that we have been able to accomplish. But this is the framework in which we hope that, again, if you are in our department, and this is I'm presenting this as a way that, as an institution and from a departmental standpoint, you can begin to address some of these issues around equity and inclusion and social justice. And so we're doing that in 6 domains: environment, achievement, leadership, development, recruitment, innovation, and outreach. So I'll just go quickly. That's our mission, again, because we hold tight to our mission. We look back on our mission. I look at this slide and I think about these things a lot because this is our why. And so all the things we do are based on that. So in the environment arm, we are committed, and this Michigan Promise really is our promise that if you come here, we will create an environment for all surgeons to be successful. And we're going to do that by making sure our environment fits that. And so cultural competence, the cultural complications is one way that we're doing that, where Dr. Leslie Dossett is leading that up. And it's presenting cases where we sit there and we talk about it, things that are happening that might be anti-culture. We now are able to speak of that in a setting like Grand Rounds or in a setting like our M&M. Bias awareness, and so every faculty member 2 years ago sat through a bias training. It's called STRIDE. It's the University of Michigan bias training for recruitment. And so every faculty member did STRIDE training. We talk a lot about implicit bias. You probably won't find a faculty member in our department that cannot talk in really more than superficial terms what implicit bias is. And so we're working hard on bias, on culture, cultural competence. Most recently, we launched a initiative called the HOPE Collaborative. It's Health Equity, Opportunity, Pipeline, and Education. This is our way of doubling down on community service. And so this will be a robust community service project where we're going into the community and understanding how we as doctors can put kids into a pipeline and begin to address their needs in a comprehensive way, addressing health equity, giving them opportunities, prepping them for the pipeline, and closing their educational gaps. We're partnering with the School of Education and the law school and other schools within the institution for that. This was that STRIDE training I talked about. This is just a picture. We packed our auditorium where 100% of faculty and house staff were trained. Achievement, also, we're gonna help people achieve. And so this arm houses things like faculty launch teams, mentorship, academic promotion planning. We have an early career development program. I'll just go fast through here because I want to get to the end for questions. These are mentors that serve in our launch teams, which is our team. Every new faculty member that starts at Michigan, they don't get one mentor. They get a team of mentors. And so we thought mentorship is really important. And so that's the way, that's how we do it. We were really, just Dr. Dimick started the leadership development program. And really, I think that this was we call this sort of set the tone for the Michigan Promise. It set the background. It provided a space for us to all learn and grow. In fact, we built the Michigan Promise as we were all taking the leadership development program. And so we're really, leadership development is, goes without saying how important that is for faculty to be successful. This is an example of an exchange program where we're sending faculty to other institutions as junior faculty, just to give them visibility, the opportunity to be visiting professors. Innovation, so teaching surgeons how to do accelerated business engagement. We have an innovation prize each year. We have a directed sabbatical where surgeons can take 8 weeks of professional development time after their 4th year and take a small sabbatical. So these are some examples of faculty that have done that. Outreach, and so we talked about the HOPE Collaborative. We have a Center for Global Surgery, the Women in Surgery program. Recruitment, we have doubled down on recruitment. We have completely changed the way that we recruit all faculty. So if you are interviewing, or if you've interviewed at Michigan, you sat in that room where a diverse team did a group interview. We have developed standard recruitment practices. The idea for this is to increase our reach. The idea for this is to level the playing ground for all faculty to be able to interview at Michigan and be successful in the interview process. We follow very strict protocols and rules around this. All of us on the committee have committed over the last 3 years to learn more about how to lower the influence of implicit bias during the recruitment process. The committee is trained. We have rules around where we post and how we post for positions. We have rules around how we form our candidate pool. I'll just go through here. One of the cool things that we do, we call this is similar to the Rooney Rule in football, where they said they had to have at least one underrepresented minority candidate come to campus. We're calling this we called it the Mulholland Rule. Now I guess we'll call it the Dimick Rule. But for every hire, the candidate pool has to have at least one underrepresented minority or one woman. And this has really helped us increase the diversity of our faculty over the last 2 years. We do standard attribute-based questions. We also do a letter that is where we rank the candidates, and we give very, very objective feedback. The chairs and the division chiefs have empowered this committee. They participate and have a very active role in each recruitment. So that's the Michigan Promise, and that I'll stop there. This is really just one institution's, I can't say that this is not a reactive or a response, but these are the things that we have been working on over the last 2 years, which I think are very timely, particularly in some of the really tough societal things that we're facing today.
Awesome, great. Thanks so much, Erika. We're gonna sort of try to put the questions at the end. Colin, do you wanna?
Yeah, our next talk is by Dr. Justin Dimick, who's a chair of surgery at the University of Michigan, who's also a past president of the AAS, and he'll be talking about allyship.
Thank you, Colin, and thank you all for the invitation to speak today, and thank you for doing this. As a past president of the AAS, I'm really proud of all the action you guys are taking and the work that you're doing in the society. The AAS is the future, and has always been the most diverse and dynamic society. And I'm proud to be a past president. Giving the podium tonight, I'm incredibly humbled to be invited to speak on the topic of allyship. I will say that allyship or bystander, or those are titles that you cannot claim. They have to be given to you. So I will reframe my comments from saying how to be a bystander, which is what I was asked to talk about, and talk a little bit about my own personal story. Erika has told you sort of our institutional story and how we're kind of working together to improve our department in this regard. But I'm going to tell you my personal story, and I'm being asked to speak on this panel as a white male. I'm going to speak predominantly to the white people on the call today, and there are a lot. I scrolled through the participant channel, and it looks like it's a majority of non-minority people on the call. So it's predominantly to you who I'm going to address my comments. So I think as I said, you can't claim to be an ally or a bystander. I personally am on a journey to understand my privilege and to understand implicit bias in a way that makes me a more effective bystander and ally. And this is a journey that I don't think you ever will finish. The opportunity to act as an ally presents itself many times and is probably missed. And my goal is to miss fewer of those opportunities. And so that's what I'll say. I'm on that journey. And so the questions I essentially have just a few questions for the majority of non-minorities on the call. First question is, have you come to terms with your privilege? This is something that I am still working on and still understanding the way in which the color of my skin gives me unfair and undue advantages. I'll say there are many moments where my eyes are opened by things that happen around me, and I'll give you an example. Last year, my first year as a chair, my first week of my first year as chair, there was an event in my health system where one coworker left a noose on the desk of another coworker. And I thought I was well prepared to be a chair, but I have never felt so unprepared to lead an organization when that happened. And it made me kind of shocked me to my core with kind of my lack of preparedness for that. And I went to a town hall, and I remember a faculty member stood up and she said, as a Black woman faculty member, I see these events happen on TV and I cry and I come to work and everyone's just going about their business as if nothing had happened, right? And that's generally how things go. And, with the George Floyd video was particularly, acts as an event, but this isn't an event, right? This is an ongoing stream of a burden that's carried by individuals in our departments. And I remember seeing that, and I realized I was complicit in that. I was one of those people. I could go about to work, I could watch it, I could be like, that is terrible, I can't believe that's happening, and come to work and act like nothing was happening. And that felt an incredible, I finally started to understand the privilege that I carry. And I'm still having many events like that. So my suggestion to you is that if you haven't started to realize that, you should do that. And don't ask the minorities in your department to educate you, do it yourself. Read, everybody who cares about this should have a stack of books that looks like this, okay? They're all bestsellers on the New York Times this week, and you should buy some of them and read them. The other thing is, the question is, do you see implicit bias everywhere that you look, right? I've been studying and thinking about leadership for a long time, and I'm fascinated by people science, the invisible barriers that connect people, and how things like self-awareness and emotional intelligence can lead to leadership. And I remember sitting listening to Caprice Greenberg's talk on gender bias, and just listening to her list one after another, all these different ways of seeing the world and these interconnections between people that I think a lot of people in the audience hadn't really thought of that way. And of course, there are that same people science applies to the biases around gender and race. And what are you doing to educate yourself around those? And what are you doing to interrupt them when you see them? And what are you doing to effectively remove them from your workplace? right? Those are kind of the challenges and the questions. The third thing is, who are you mentoring and sponsoring? You know, do we have a strong predilection for people who look like us and who have interests like us? So if you look at your mentees, do they all look just like you? And there are definitely parts of my career where I can say that that is the case, where I gravitate to people that are like you, and because you like spend time with them, have similar hobbies. And I think everybody needs to do a mentorship biopsy and say, who are you mentoring the next generation in an equitable way? Do you create equitable mentorship and sponsorship opportunities in your department? And along those lines, like, what signals are you sending? Are you sending signals that you're open to mentor only people that look like you, or are you being inclusive in how you broadcast your mentorship availabilities? If you're a leader, or if you are in charge of a program, are you creating space in your curriculum for discussing and helping other people learn about implicit bias and privilege? And we heard one allusion today to the cultural complication curriculum. That's one thing that we're doing, where we use the time in M&M that already exists to discuss cases where our culture has been complicated by acts of gender or racial abuse. And then finally, the title bystander. I learned that being a bystander is great, and interrupting bias when you see it is great. But one of my mentees from OB-GYN, Michelle Moniz, one of my many mentees that I learn more from than I teach, taught me about the term upstander. And upstander is somebody who is using their power and their platform to change policies and procedures. And I think you just heard Erika give an example of all the policies and procedures that we're working to change at Michigan. And so I think that going beyond bystander and using your platform to change policies and procedures to be equitable is what we should all strive for. And I'd say I have not figured this out. I am on a journey of recognizing my privilege, increasingly being able to recognize and see bias so that I can intervene, and then using my powers and the platforms that I have and the privilege that I'm afforded by being a department chair to be an upstander and create policies and procedures that drive us towards an inclusive culture and an equitable workplace. Thank you.
Great, thanks so much, Justin. A lot of questions coming in. We're gonna really try to get to as many of them as we can. I wanted to introduce Dr. Fayanju. She's the Assistant Professor of Surgery and Population Health Sciences at Duke University School of Medicine. And she's also the Associate Director of Disparities and Value in Healthcare with Duke Forge. Her research is focused on health disparities, particularly in breast cancer, and she is actually KO8 funded from the NIH. She's going to talk with us a little bit about our role as surgeons and specifically within the context of the AAS in addressing healthcare disparities through research. So Lola, thank you.
Well, thank you very much for the privilege of being able to speak with this wonderful group. Back to the beginning of my presentation. So I want to speak briefly about our role as surgeons in addressing healthcare disparities through research. I have no disclosures on what you see here. So I wanted to start by just defining some of the terms, because I think we throw the words disparity and equity around a lot. But they have a plethora of definitions, but I want to condense them to ones that we can hopefully all agree upon and use going forward. So a health disparity is an observed intergroup difference in health screening, outcomes, or treatment that is rooted in inequity. And I think we'd all like to believe that if something is unjust, it likewise should be avoided and can be avoided. There are many definitions from around the world through World Health Organization, CDC, et cetera, but I find this one particularly compelling because it introduces the notion of what is unequal and what is unjust. In contrast, health equity represents a distribution of health according to clinical need. That is, when you take out of it, what patients' preferences are, what the baseline prevalence of a condition is in the community, how are people getting access to the resources they need, and are those access levels equal across groups? And again, it speaks to the idea that we should be looking for justice in medicine, but it takes us to the fact that we may not always share a common view of justice. With regard to health disparities in research, the first question that I hope we don't have to pose here, but is important to reckon with is there a problem at all? With regards to clinical trials, for example, we know that Hispanic people make up about 15 to 20% of the US population, but only 7 to 8% of those who participate in clinical trials. However, when you look at representation of ethnic groups across different types of trials, African Americans and Latinx individuals are overrepresented in phase 1 trials and underrepresented in phase 3 trials. So precisely in the trials that demonstrate efficacy, or rather safety, there are more of them. And then in trials that actually are of some opportunity for individual benefit, there are fewer. And it makes us think about a number of things. What does the consent process look like? Is there any possibility that therapeutic misconception on the part of ethnic minorities or people with less education is being exploited in order to increase enrollment in phase 1 trials? Is there a failure to convey the goals of phase 1 studies to people who are being approached for trials? And then to what extent is enrollment bias affecting who gets an opportunity to participate in these landmark phase 3 trials that compare standard of care to something new, innovative, and potentially life-saving? When we look at health services research, you might think, well, we're looking at data that's already been collected. How can that be affected by bias? Well, the concern is that even things like the NIS or NISQIP actually reflect practice patterns in every state. And you have to think about how that data has been collected. SEER, for example, is limited to less than half of the states in the United States and doesn't include coverage of actually most of the major US cancer centers. Likewise, NCDB includes about 70% of cancer cases in the United States, but because it only draws from Commission on Cancer accredited institutions, there's a good chance that many of them serve communities that have fewer oncologists, that are more rural areas, that are underserved in various dimensions may not be represented. Something notable is that if you're thinking about particularly looking at disparities across groups or looking at outcomes in a particular group, one needs to be thoughtful about the database you use. So for instance, the SEER database, as I mentioned, is not exactly representative of the US population. So it allows for people to potentially look in greater depth at groups that are otherwise underrepresented and what are more nationally representative databases. So what's at stake and for whom when we think about disparities in research? In 1993, the US Congress actually passed an act that was particularly developed in order to encourage participation of women and racial and ethnic minorities in NIH-sponsored research. And the question is, what's changed in over 25 years? We sought to examine that with regards to breast surgical oncology patients. And what we did is we looked at about 800,000 patients who were trial eligible for trials in which there was either a breast surgery intervention or you had to have had breast surgery in order to be eligible. And we compared them to individuals who participated in over 14 cooperative group trials. And we wanted to see what factors were associated with trial participation, as well as what the race-specific trial participation rates looked like over time. And what we found is that actually participation declined across all racial ethnic groups over time, which is not that surprising given that the nature of our understanding of breast cancer has changed a lot, and trials have become more subtype specific and smaller. Not surprisingly, we did find that being Black or being Hispanic meant that you were much more likely to participate in a trial when other factors were controlled for. But notably, we found significant interactions between income and race and ethnicity. Notably, we found that high-income Black patients were approximately 50% less likely to participate than lower-income Black patients. And that can be for a number of reasons that obviously can't be explored just through looking at retrospective data. But nonetheless, we can conclude that differences in trial participation parallel and reflect a complex interaction between race, ethnicity, socioeconomic status, and other demographic factors. Thus, we'll need a diverse array of interventions to facilitate equitable trial participation. With regards to breast cancer, but I suspect with regards to many conditions, as we learn more about the biology of disease and the various social determinants of health that contribute to how disease manifests itself in individuals and across populations, future trials need to be increasingly biology-driven, subtype-specific, and clinician-informed. So for example, in breast cancer, we know that ethnic minorities, particularly Black women and women who are of Hispanic ancestry, are at increased risk for experiencing triple-negative breast cancer. If we fail to include those women in trials looking at solutions to treating triple-negative breast cancer, we are precisely failing to inform our collective knowledge about how this disease is treated and what our opportunities are for improving treatment across the whole group of the population. And then the question is, who is at the table when decisions are made about how trials are developed, who should be prioritized for enrollment, and what diseases should be prioritized for study. There are a lot of reasons that it's hard to do health disparities research well. One is that we can't always agree upon the definitions for what is disparity and how it should be approached. The scale is challenging. In some ways, it's incredibly overwhelming because almost every study you'll look at will say that there's a disparity across racial and ethnic groups. At the same time, some of these studies will say that they're underpowered to sufficiently address particular characteristics to hopefully kind of expand upon why we're seeing disparities in a particular ethnic minority group. There are potentially conflicting stakeholder priorities with researchers, funding agencies, and patients all having different ideas of what should be prioritized and what should be the focus of both funding as well as innovation. It may require non-traditional methods, including qualitative methods, in order to get at the answers that may lie behind some of the questions that we ask. Thinking about disparity is something that I think needs to be incorporated at the conception of an idea, not something that's thought of later on as one of many secondary analyses. And then finally, the question is there an adequate reward? That is, how likely is it and how hard is it to get disparities research published? So I'm going to tell you, it's actually very challenging. And the truth of the matter is, we don't know what we don't know. So even if you're trying to publish disparities work in a journal that doesn't specifically look at disparities, it's very striking the extent to which the editors and the reviewers who are asked to look at your work may not be aware of the baseline problems that exist, as well as the likely contributions to the things that we're seeing. I want to share with everyone a review of a manuscript that I recently submitted. And I share it to give you an example of the kinds of things that you sometimes receive if you deign to do disparities work. This individual critiqued our thought that maybe we should not think of Hispanic people as one homogeneous group in studies, that we should probably think about how to disaggregate race and ethnicity for various reasons. And this individual wrote, the subdivision of Hispanic into 4 subgroups is problematic. Blacks are Blacks, Indigenous are not Hispanic, white can be, Hispanic or non-Hispanic, and others need greater clarification. Need a more meaningful categorization before proceeding. These are political designations and have no place in science. Compare Hispanic and non-Hispanic white women, get rid of everybody else. And this was from Cancer. This is not from a journal that you haven't heard of. This is a journal that's telling us that a reviewer who would offer a review like this should be in charge of being a gatekeeper for getting disparities work into publication. So why do we have to do this better? First of all, conceptual blind spots lead to poor study design. I was recently in a tumor board where we were trying to decide on how to proceed with treatment for a young woman who has a fairly aggressive hormone receptor positive breast cancer. And someone then commented in the room that when she'd gone to another institution, because she's of Asian ancestry, there was some concern that actually Asian American women had been underrepresented in the Oncotype DX preliminary trial, and therefore they weren't sure whether that data should actually be applied to that population. And it was one of those things where you can hardly believe that something that was that important and that critical to our understanding of how systemic therapy should be used in breast cancer would have such a glaring hole. But it's an example of how we sometimes are kind of later on thinking about how the results of trials can inform the way we practice good medicine. Obviously, there's decreased generalizability if we don't have diverse trial cohorts. And there's a danger of using race ethnicity as a proxy for genetic variation, when in fact, race and ethnicity are social constructs that are very, very, very poor approximations of genetic variation. But if we don't include them at all, we don't even begin to address some of the baseline differences in genetic prevalence, but also the many, many, many social determinants of health, as well as perceived bias on the part of patients, as well as transmitted bias on the part of providers that contribute to why we see the outcomes that we do and people get the treatments that they do. Disparate treatment leads to disparate outcomes. It means we're going to have higher rates of recurrence for cancer or death or progression or what have you. And those things inevitably lead to costs that we, frankly, as a healthcare system cannot afford. Lost opportunities. You know, I think one of the things that's so tragic about thinking about premature death or avoidable death is you're not just thinking about patients who might have survived the cancer or the condition that you were studying or taking care of. You're also thinking about all of the quality adjusted life years. You're thinking about the role that person played in the community. You're thinking about the way in which that was someone who could have been someone's father, someone's mother, someone's future doctor. And that's lost when we don't really take the time to save these individuals and think about how to focus our research on helping everyone who comes through our door. And then I think this is something that, I really think is very, very important. Demography changes while power sleeps. Before we know it, the United States is going to be a majority non-white country. And if all of our trials for our most common conditions have been based on populations that are increasingly less well represented, it means we're not only getting a good way to treat ethnic minority patients, we're going to be collectively practicing less good medicine across the board. And obviously, the reason we should be doing better health disparities research is because it's the right thing to do. So I want to quickly provide a framework for better science, because I think it's one thing to say things are bad, this is why they're hard, and another thing to say how we can make it better. So my first piece of advice is to be humble. Get more training. Don't assume that just because you're someone who can include race and ethnicity in a logistic regression model that you understand how disparities work or how the results of your research should be interpreted. There are various resources, both intra-institutional as well as across the country, that you can use to educate yourself about how to do good disparities research. Make friends. Often, the people who know most about how to understand racial and ethnic disparities in research are not going to be surgeons. They're going to be people who do different types of research methodology than you. They're going to be people who may not even be academics. They may be community leaders. They may be collaborators who are engaging with race and ethnicity in different contexts, but nonetheless can provide a lot of elucidation for you and the questions that you have. You have to be intentional. There are various grant RFAs that specifically target disparities. One that even targets surgical disparities. That is an R01 level mechanism that just recently had closed submission, but has another cycle coming up. The American College of Surgeons has a committee on healthcare disparities. And then there are various other kinds of groups that allow you to perform clinical trials as well as other types of research in diverse groups that specifically have patients who aren't otherwise always included in clinical trials. Part of this intentionality is thinking about who is on your team. Who are your collaborators and how do they complement you? Who is your statistician? What are her priorities? Is she the kind of person who will only be thinking at race ethnicity, again, at the end, as something to add into the model when you're looking for p-values, when you're considering publication? Who is recruiting and counseling your patients? Are they taking into account the concerns of a huge, diverse group of people? The same tactics and same language that you're going to use for a 45-year-old Black attorney is not going to be the same tactics you're going to use for an 80-year-old Hispanic woman who lives with her family. They're going to be different. Are you equipped to provide the appropriate materials, the appropriate context, and to take seriously the biases you bring in terms of who you approach for research and how you bring them into the study? And then finally, how are you incentivizing participants? Are you sufficiently thinking about what they are experiencing and encountering when they come to your hospital for care, and how that might possibly be leading them to not want to participate in research? Again, who is at the table when decisions are being made? And then finally, why surgeons? Our world has changed forever as a result of forces that are both viral and systemic. And I would argue that the reason that surgeons are perfectly placed to address disparities in research and to respond to the factors that have been raised to our collective consciousness by the COVID-19 pandemic and by the police brutality and Black Lives Matter movements that we've seen are that surgeons are very committed to truth-telling. We don't beat around the bush. We try and help people get better because we're committed to finding excellence in everything we do. Dynamism defines us, whether that's responding to aberrant anatomy in the operating room or thinking of a new way to make an old operation better. We are drawn to doing things hard, and we all want to do what's right. We have an obligation to be at the table. So although the title of my talk was Our Role as Surgeons in Addressing Healthcare Disparities Through Research, I would like to hope that I've convinced you that it is our obligation as surgeons to address health disparities through research. And I welcome you to this platform for all others who are interested in exploring disparities work for the first time or incorporating it into the work that you already do. Thank you.
Great, thank you so much, Lola. So we're going to invite Dr. Kim to just talk with us a little bit about the AAS commitment to addressing racial discrimination in academic surgery. Dr. Kim is the current president of the AAS, and he's a professor of surgery and pediatrics at the Keck School of Medicine at USC. His clinical expertise is in pediatric surgical oncology. He's going to talk with us a little bit about the AAS and what this all means to him and the organization.
Thanks, and thanks for everyone who signed in this evening. So very proud of the work that Callie's done with the DI task force, and Colin and all the other members, particularly the leadership who have found the recent events to be so striking, and for a need for our own society to step up and combat some of this racial discrimination in academic surgery. And so I think what we've seen and what we've heard is that there's conscious and unconscious bias, and this leads to the fact that the opportunities are not the same for all surgeons, particularly underrepresented minorities, that the path to promotion is more arduous, and those opportunities to get you promoted are more difficult to come by. Preconceived notions may come along with that, and as we now know, there's a lack of role models, and it's difficult to join a specialty when you don't see a lot of role models who are leading the charge and showing the way. The AAS response started off more formally last year with past President Carl Villamoria, who set up this Diversity, Equity, and Inclusion Task Force. And it took in our representatives from SBAS, the SAS, the Asian Society, the Latino Surgical Society, the AWS, as well as members from the LGBTQ community. And Dr. Clarke and the committee recently revised and updated our diversity statement, and it can be found on the website here and goes through these different points. And I think most notably that we will not be silent and stand by quietly as things happen, but we will call out things when we see them and when there are things that are clearly wrong in our society and in our specialty. But, you know, we talk about equality, and we have, I should go back here. So, you know, I have to give credit to the past presidents, particularly I recall Dr. Pollock and Dr. Dimick in the past, and how they went about bringing a period of fairness and transparency to our society, and particularly to our executive council. And this led to open election of committees, self-nomination for committee chairs. It was no longer purely by appointments and backdoor, but people self-nominated and put themselves on the ballot. And I think in general with our executive council, we saw increased diversity in areas that we needed to see it. Institutional, some smaller institutions, surgical specialties that weren't classically part of the AAS leadership, research backgrounds, basic versus clinical, but also with regards to gender, race, and sexual orientation. And we talk about equality and having everybody have an equal opportunity. So, you know, sure, everybody has an opportunity to be on the ballot. And through this, we did see improved diversity in institutions, research, and specialty. But we didn't really see an improvement in diversity in race and sometimes gender. And sometimes equality started to look like this. And as we all know, equality does not necessarily mean equity. And so, particularly in this time period, you know, it was upon us to think about what are some ways that we can improve the racial equity in the AAS. And these are things that we are currently working on now. One thing I've realized is you can't just have everyone have equal opportunity and hope that it works out for everybody. You have to be intentional with our actions. You have to be purposeful. And so we're going to utilize some appointments that we can have to have and expand the diversity of some of these committees, as well as look at our committee chairs and to expand that as well. We had already developed mentorship sessions, and these will be rolling out in the next few months with regards to surgical specialty, with regards to research specialties, to be able to meet with various leaders in those fields. And I feel this is a perfect opportunity to have mentorship sessions with regards to underrepresented minorities, to meet with the AAS leadership in small groups, to ask questions about academic surgery, about societies, anything, but to give them that contact and that opportunity. As you've heard so far, we have the DEI task force, and we have emboldened them to create new programs to develop more diversity in our society. And lastly, you know, I would say that we have to use our privilege. Our privilege is our society, our privilege in leadership. And for everybody who's joined this evening, you too have privilege. You have graduated from great colleges, you've graduated from great medical schools. Many have already completed their surgical training. And in that sense, you are in a position of privilege. And I ask that you use that platform to lift others up, to shine a light on those who've been left in the dark for too long. And so I ask all of you to help us, that we can come up with some ideas, but we need your help. And I've left my email address right there, and I welcome your thoughts and your ideas to help our society to become stronger.
Great, so thank you so much. We're out of time and we didn't get to all the questions, but we tried to get to most of them. Thank you guys again so much for participating. As Eugene mentioned, we are really committed to working on this in the AAS. I am particularly very committed to working on these issues through the DEI committee, and we're looking for suggestions as we put forward our platform to the leadership for programmatic change, things that we can implement that will address faculty recruitment and retention on a national scale. We're a national organization and we can make some meaningful work, but also about training experiences and possibly even being sort of a place for people to come and seek more training on diversity, equity, and inclusion issues. So please feel free to reach out to me directly on Twitter with any suggestions, ideas, or questions. We have an entire committee that's working on this, and we welcome any feedback. I really want to thank our speakers. I think you guys all did a really fantastic job in a very small period of time to try to get to some of the nuances of what we are seeing from a racial discrimination standpoint in academic surgery. This is one of many town halls that we'll be hosting on this particular topic. So if we didn't get to your question, I promise you we'll get to it again. Again, thank you all so much for participating, and we look forward to hearing from you guys soon. Thanks, everyone. And thanks, Nicole and JJ, for organizing this. This was fantastic.